My topic is Vemurafenib in multiple non-melanoma cancers with Braf. Introduction. Braf B600 mutations occur in approximately 50% of cutaneous melanomas and result in constitutive activation of downstream signaling through the mitogen-activated protein kinase pathway. Vemurafenib is a selective oral inhibitor of the Braf B600 kinase and is associated with a response rate of approximately 50% and improved survival among patients with Braf B600E mutation positive metastatic melanoma. Efforts by the Cancer Genome Atlas, another initiative to characterize the genetic landscape of most tumor types, have identified Braf B600 mutations in non-melanoma cancers, including colorectal cancer, non-small cell lung cancer, papillary thyroid cancer, diffuse gliomas, cholangiocarcinoma, hairy cell leukemia, multiple myeloma, Langerhans cell histiocytosis, and Erdheim-Chester disease. In some of these cancers, the Braf B600 mutation is associated with an aggressive disease phenotype and shortened disease-free and overall survival. In more than half of the non-melanoma cancer types in which Braf B600 mutations have been identified, the incidence of mutations is less than 5%. The efficacy of Vemurafenib in this non-melanoma cancer has not been systematically explored despite its considerable therapeutic potential. The large number of tumor types involved, the low frequency of Braf B600 mutations, and the rarity of some of the cancers make disease-specific studies difficult to conduct. To address this important unmet clinical need, we designed a histology-independent, flexible early phase 2 basket study of Vemurafenib in patients with non-melanoma cancers harboring Braf V600 mutations. This study design allows for the enrollment of patients with various types of cancer. Our study included 6 cohorts of patients with pre-specified cancers: non-small cell lung cancer, ovarian cancer, colorectal cancer, cholangiocarcinoma, breast cancer, and multiple myeloma, as well as 7 cohorts which permitted enrollment of patients with any other Braf B600 mutations positive cancer. Method. We enrolled patients in 6 specified cancer cohorts. Patients with all other tumor types were enrolled in the 7 cohorts. A total of 122 patients with Braf B600 mutations positive cancer were treated, including 27 patients with colorectal cancer who received Vemurafenib and cetuximab. The primary endpoint was the response rate. Secondary endpoints include progression-free and overall survival. Assessment. Tumor assessments were performed by means of computed tomographic or magnetic resonance imaging of the chest, abdomen, and pelvis at baseline, and then every 8 weeks until disease progression, death, or withdrawal from the study. Patients with multiple myeloma were evaluated according to the IMWG criteria. Information on survival and new anti-cancer therapy was documented every 3 months in the follow-up period. Cancer Institute Common Terminology Criteria for Adverse Events, version 4.0, until day 28 after discontinuation of this study treatment. Results. In the cohort with non-small cell lung cancer, the response rate was 42%, and median progression-free survival was 7.3 months. In the cohort with Erdheim-Chester disease or Langerhans cells histiocytosis, the response rate was 43%. The median treatment duration was 5.9 months, and no patients had disease progression during therapy. There, there were anecdotal responses among patients with pleomorphic xanthoastrocinoma, anaplastic thyroid cancer, cholangiocarcinoma, salivary duct cancer, ovarian cancer, and clear cell sarcoma, and among patients with colorectal cancer who received Vemurafenib and cetuximab. Safety was similar to that to prior studies of Vemurafenib for melanoma. Conclusions. Braf B600 appears to be a targetable oncogene in some but not all non-melanoma cancers. Preliminary Vemurafenib activity was observed in non-small cell lung cancer and in Erdheim-Chester disease and Langerhans cell histiocytosis. The histologic context is an important determinant of response in Braf B600 mutated cancer.